Question 1. A 68-year-old male presents with sudden onset of severe abdominal pain radiating to his back. He has a history of hypertension and is hypotensive with a weak, rapid pulse. Your most immediate and critical management priority, after establishing airway and breathing, is to A. Administer a bolus of 500 milliliters of intravenous normal saline. B. Prepare for rapid transport to a trauma center. C. Obtain a detailed medical history from the patient's family. D. Apply a non-rebreather mask at 15 lpm. Answer: B. Prepare for rapid transport to a trauma center. This question tests your ability to prioritize in a potentially life-threatening medical emergency, specifically an abdominal aortic aneurysm, AAA. The keywords sudden onset severe abdominal pain radiating to his back, history of hypertension, and hypotensive with a weak, rapid pulse are highly suggestive of a ruptured AAA, which is a surgical emergency. While 4 fluids and oxygen are important supportive measures, the most critical intervention is immediate transport to a facility capable of definitive surgical repair, as pre-hospital time significantly impacts survival in these cases. Focusing on rapid transport acknowledges the need for definitive care that cannot be provided in the pre-hospital setting. Your immediate priority is always to get the patient to the right place quickly when definitive care is surgical. Question 2. A 3-year-old child is in severe respiratory distress with inspiratory stridor, a barking cough, and appears anxious. Her mother states the symptoms started suddenly after the child choked on a small toy. Which of the following is the most appropriate initial intervention? A. Administer nebulized racemic epinephrine. B. Attempt to visualize the airway with a laryngoscope. C. Perform back blows and chest thrusts. D. Provide humidified oxygen and transport rapidly. Answer: C. Perform back blows and chest thrusts. This scenario tests your understanding of foreign body airway obstruction, FBAO, in pediatrics, specifically differentiating it from medical causes of stridor. The keywords suddenly after the child choked on a small toy are crucial and indicate a likely FBAO, not an infection like croup or epiglottitis. In a conscious infant or child with a severe airway obstruction, the most appropriate initial intervention is to perform foreign body removal maneuvers, such as back blows and chest thrusts, for infants, or abdominal thrusts, for children. While oxygen is important, addressing the obstruction directly is paramount. Remember, in a choking emergency, direct intervention to dislodge the foreign body takes precedence over supportive care. Question 3. You are assessing a patient in cardiac arrest. After 5 minutes of high-quality CPR and defibrillation, the patient regains a pulse and begins to breathe spontaneously. Which of the following is the most critical immediate post-ROSC intervention? A. Administer a fluid bolus of normal saline. B. Obtain a 12-lead electrocardiogram. C. Secure the airway with an advanced airway device. D. Initiate targeted temperature management at 33 degrees Celsius. Answer: B. Obtain a 12-lead electrocardiogram. This question evaluates your knowledge of post-cardiac arrest care priorities. The keyword immediate highlights the need for a critical next step after return of spontaneous circulation, ROSC. While airway management and temperature control are vital for long-term prognosis, the most immediate and critical action post-ROSC is to identify and treat the underlying cause of the arrest, especially cardiac etiologies. A 12-lead ECG is crucial for identifying ST elevation myocardial infarction, STEMI, or other life-threatening arrhythmias that require immediate intervention, such as percutaneous coronary intervention, PCI. It's essential to look for treatable causes of the arrest as soon as a pulse is restored. Question 4. A 22-year-old male is found unconscious with pinpoint pupils and shallow respirations at a rate of 6 breaths per minute. His skin is cool and clammy. Naloxone 0.4 mg 4 is administered, and within 1 minute, his respiratory rate increases to 18 breaths per minute, and he becomes responsive. Which of the following is the most important next step in management? A. Discontinue oxygen and monitor. B. Administer an additional dose of naloxone. C. Monitor for recurrence of respiratory depression. D. Transport without lights and sirens. Answer: C. Monitor for recurrence of respiratory depression. This question tests your understanding of opioid overdose reversal and the pharmacokinetics of naloxone. The keywords pinpoint pupils, shallow respirations, and naloxone, respiratory rate increases confirm an opioid overdose with successful reversal. Naloxone often has a shorter half-life than many opioids, meaning the effects of the opioid can return, leading to recurrent respiratory depression. Therefore, it is critical to continuously monitor the patient's respiratory status for a rebound effect. While the patient has improved, the job is not over, and a second dose might be needed if respiratory depression recurs. Always anticipate the possibility of the opioid's effects outlasting the naloxone. Question 5. You arrive on scene of a single vehicle rollover. The driver, a 40-year-old male, is entrapped, conscious, and complaining of severe lower extremity pain. You note significant deformity to his left femur and obvious external bleeding from a laceration on his thigh. After ensuring scene safety, what is your most immediate priority? A. Initiate spinal immobilization. B. Control the external bleeding. C. Administer pain medication. D. Assess distal neurovascular status. Answer: B. Control the external bleeding. This question assesses your trauma primary assessment priorities in a dynamic environment. The keywords obvious external bleeding and significant deformity to his left femur indicate a severe injury with potential for significant blood loss. While spinal immobilization and neurovascular assessment are important, active hemorrhage control is the most immediate life-saving intervention in trauma. Uncontrolled external bleeding can quickly lead to hemorrhagic shock and death, making it the highest priority after ensuring scene safety and assessing airway and breathing. Remember, life threats are addressed in order, A, B, C, D, E, with C, circulation/control of bleeding, coming before D, disability/spinal immobilization, if there is active hemorrhage. Question 6. A 78-year-old female with a history of heart failure complains of sudden onset of severe shortness of breath. She is sitting upright, accessory muscle use is noted, and you hear crackles bilaterally in her lungs. Her skin is pale and diaphoretic. Vital signs are BP 180/100, HR 110, RR 30, SpO2 88% on room air. Which of the following is the most appropriate initial pharmacological intervention? A. Nitroglycerin sublingually. B. Albuterol nebulized. C. Furosemide 4 push. D. Aspirin orally. Answer: A. Nitroglycerin sublingually. This question tests your understanding of the immediate management of acute decompensated heart failure with pulmonary edema. The keywords heart failure, sudden onset severe shortness of breath, crackles bilaterally, BP 180/100, and SpO2 88% point to cardiogenic pulmonary edema. Nitroglycerin is a potent vasodilator that reduces preload and afterload, decreasing the workload on the heart and improving pulmonary congestion. While oxygen and possibly CPAP are crucial, nitroglycerin is the most appropriate initial pharmacological intervention to quickly alleviate fluid buildup in the lungs. Albuterol is for bronchospasm, furosemide takes longer to act, and aspirin is for cardiac ischemia. Remember, reducing the heart's workload is key in these scenarios. Question 7. You are assessing a 55-year-old male who complains of crushing chest pain radiating to his left arm. He is pale and diaphoretic. His blood pressure is 88/60 mmHg, heart rate is 112 bpm, and respirations are 22 bpm. He states he took Viagra 24 hours ago. What is your most appropriate action regarding nitroglycerin administration? A. Administer nitroglycerin 0.4 mg sublingually and reassess. B. Administer nitroglycerin 0.4 mg sublingually every 5 minutes for up to 3 doses. C. Withhold nitroglycerin due to his current blood pressure. D. Withhold nitroglycerin due to his recent Viagra use. Answer: C. Withhold nitroglycerin due to his current blood pressure. This question assesses your understanding of contraindications for nitroglycerin, particularly in the context of cardiac emergencies. The keyword BP 88/60 mmHg is critical here. Nitroglycerin is a vasodilator and can cause a significant drop in blood pressure, which is already low in this patient. Although recent phosphodiesterase inhibitor use like Viagra, the Viagra 24 hours ago is a distractor, as the contraindication window for Viagra is typically 24 hours, and for Cialis/Levitra, it is 48 hours, is a contraindication. The immediate and most pressing contraindication in this scenario is the patient's hypotension. Administering nitroglycerin to a hypotensive patient could worsen shock. Always prioritize addressing immediate life threats and contraindications. Question 8. A 4-year-old child falls from a second-story window. On arrival, the child is unconscious, unresponsive to verbal stimuli, and has decorticate posturing. Vitals are BP 90/60, HR 130, RR 10, SpO2 92% on room air. What is your most appropriate airway management intervention? A. Insert a nasopharyngeal airway, NPA, and apply a non-rebreather mask. B. Perform a head tilt chin lift maneuver and apply oxygen. C. Prepare for rapid sequence intubation, RSI, if local protocols allow. D. Administer positive pressure ventilation via bag valve mask, BVM, with an oropharyngeal airway, OPA. Answer: D. Administer positive pressure ventilation via bag valve mask, BVM, with an oropharyngeal airway, OPA. This question tests critical thinking in pediatric traumatic brain injury and airway management. The keywords unconscious, unresponsive, decorticate posturing, and RR10 indicate severe neurological compromise with inadequate breathing. While RSI may be a definitive airway, positive pressure ventilation via BVM with an OPA is the most appropriate immediate intervention to address hypoventilation and hypoxia, which are detrimental in TBI. A head tilt chin lift is contraindicated with suspected spinal injury, and NPA is not appropriate for a patient needing positive pressure. Securing an adequate airway and ensuring ventilation is paramount before considering advanced procedures. Always prioritize effective ventilation over immediate intubation if BVM ventilation is achievable. Question 9. You are managing a 35-year-old male with a significant anterior chest injury from a motor vehicle collision. He is hypotensive, tachycardic, and has markedly diminished breath sounds on the left, with tracheal deviation to the right. Despite aggressive fluid resuscitation, his blood pressure continues to drop. What is your most immediate definitive intervention? A. Apply a non-rebreather mask at 15 lpm. B. Perform a needle decompression of the left chest. C. Initiate pericardiocentesis. D. Administer another 500 milliliters for bolus. Answer: B. Perform a needle decompression of the left chest. This question assesses your ability to identify and manage a tension pneumothorax, a critical life threat. The keywords anterior chest injury, hypotensive, tachycardic, markedly diminished breath sounds on the left, and tracheal deviation to the right are the classic triad of signs for a tension pneumothorax. This condition compresses the heart and great vessels, leading to obstructive shock. Needle decompression is the immediate definitive intervention to relieve the pressure and restore cardiac output, which fluid resuscitation alone cannot fix. While oxygen is always good, it won't resolve the mechanical compression. Knowing your critical interventions for specific traumatic conditions is essential. Question 10. A 58-year-old female is experiencing a severe allergic reaction after eating peanuts. She is hypotensive, BP 80/50, tachycardic, HR 130, has diffuse urticaria, and is wheezing with inspiratory stridor. Her SpO2 is 89%. What is your most appropriate initial dose and route of epinephrine for this adult patient? A. 0.3 mg of 1:1000 epinephrine intramuscularly. B. 0.5 mg of 1:1000 epinephrine intramuscularly. C. 0.1 mg of 1:1000 epinephrine intravenously. D. 1 mg of 1:1000 epinephrine intravenously. Answer: A. 0.3 mg of 1:1000 epinephrine intramuscularly. This question tests your knowledge of epinephrine dosing and routes for anaphylaxis. The keywords severe allergic reaction, hypotensive, wheezing, and stridor indicate anaphylactic shock. For severe anaphylaxis in adults in the pre-hospital setting, the standard initial dose is 0.3 mg, or 0.5 mg depending on protocol, of 1:1000 epinephrine administered intramuscularly, IM, in the lateral thigh. Intravenous epinephrine, 1 to 10,000 concentration, is reserved for profound shock or cardiac arrest under specific protocols and is typically administered in much smaller, titrated doses due to its potent effects. Always start with the IM route for rapid systemic absorption in anaphylaxis. Question 11. You are triaging patients at a mass casualty incident involving a bus crash. You encounter a 30-year-old male who is awake, screaming, has an obvious open fracture of his tibia, and is unable to walk. He is breathing 20 times per minute, has a radial pulse, and can follow commands. According to Start Triage, what color tag should this patient receive? A. Red, immediate. B. Yellow, delayed. C. Green, minor. D. Black, deceased. Answer: B. Yellow, delayed. This question assesses your application of the START, Simple Triage and Rapid Treatment, triage system. The keywords awake, screaming, open fracture, unable to walk, breathing 20, radial pulse, and can follow commands are crucial. According to START, a patient who can follow commands, has a respiratory rate between 10 to 30, and a radial pulse, but is unable to walk due to an injury, like a severe fracture, is triaged as yellow, delayed. Red is for immediate life threats, green for minor injuries, walking wounded, and black for deceased. This patient is not immediately life-threatened by their vital signs but cannot self-extricate, placing them in the delayed category. Question 12. A 62-year-old male with a history of COPD is found in significant respiratory distress. He is alert but fatigued, speaking in 2 to 3 word sentences. His respirations are 28 BPM, shallow, and accessory muscle use is noted. SpO2 is 85% on room air. He has a productive cough with thick green sputum. What is the most appropriate initial oxygen delivery method? A. nasal cannula at 4 lpm. B. Non-rebreather mask at 15 lpm. C. Venturi mask at 28% FiO2. D. Continuous positive airway pressure, CPAP. Answer: D. Continuous positive airway pressure, CPAP. This question tests your knowledge of advanced respiratory interventions for patients in significant respiratory distress, particularly those with COPD exacerbation. The keywords significant respiratory distress, fatigued, speaking in 2 to 3 word sentences, shallow respirations, and SpO2 85% indicate impending respiratory failure. While oxygen is needed, CPAP is the most appropriate initial intervention because it provides positive pressure to keep alveoli open, reduce the work of breathing, and improve oxygenation and ventilation more effectively than standard oxygen masks in severe distress. A Venturi mask might be used for stable COPD, but this patient's condition is severe. CPAP can often prevent the need for intubation. Question 13. You are assessing a patient found unresponsive in a supine position. There is no evidence of trauma. He has gurgling respirations and a weak carotid pulse. What is your immediate priority after determining unresponsiveness? A. Initiate chest compressions. B. Insert an oropharyngeal airway, OPA. C. Perform a head tilt chin lift maneuver. D. Check for a medical alert tag. Answer: C. Perform a head tilt chin lift maneuver. This question assesses your primary assessment sequence for an unresponsive medical patient. The keyword gurgling respirations indicates an upper airway obstruction, likely from the tongue or secretions. After determining unresponsiveness, the immediate priority is to open the airway. In a patient with no evidence of trauma, a head tilt chin lift maneuver is the quickest and most effective way to open the airway by lifting the tongue off the posterior pharynx. Inserting an OPA or initiating compressions comes after ensuring an open airway if needed. An open airway is fundamental to effective ventilation and oxygenation. Question 14. A 16-year-old female presents with severe abdominal pain, nausea, and vomiting. Her last menstrual period was 8 weeks ago. She is pale, diaphoretic, and her vital signs are BP 90/60 mmHg, HR 120 bpm, RR 20 bpm. What is the most critical assessment or intervention to consider in the pre-hospital setting? A. Administer ondansetron for nausea and vomiting. B. Obtain a detailed gynecological history. C. Initiate rapid intravenous fluid resuscitation. D. Consider the possibility of ectopic pregnancy. Answer: D. Consider the possibility of ectopic pregnancy. This question tests your ability to recognize and prioritize a life-threatening gynecological emergency. The keywords 16-year-old female, severe abdominal pain, nausea and vomiting, last menstrual period was 8 weeks ago, and signs of hypoperfusion, pale, diaphoretic, BP 90/60 mm of mercury, HR 120 bpm, are highly suggestive of a ruptured ectopic pregnancy. This condition requires immediate surgical intervention and is a cause of significant hemorrhagic shock. While 4 fluids are necessary to manage shock, recognizing the potential underlying cause is paramount for appropriate destination and patient care. Always consider ectopic pregnancy in any female of childbearing age with abdominal pain and signs of shock. Question 15. You are managing a patient with suspected organophosphate poisoning. They present with pinpoint pupils, excessive salivation, profuse sweating, bradycardia, and muscle fasciculations. In addition to supportive care, what is the most appropriate pharmacological intervention? A. Atropine. B. Pralidoxime, 2 PAM. C. naloxone. D. Activated charcoal. Answer A. Atropine. This question delves into the specific treatment for organophosphate poisoning. The symptoms described: pinpoint pupils, excessive salivation, profuse sweating, bradycardia, and muscle fasciculations, are classic signs of cholinergic crisis, often remembered by the SLUGM acronym: salivation, lacrimation, urination, defecation, GI upset, emesis, meiosis/muscle fasciculations. Atropine is the primary antidote, acting as a competitive antagonist at muscarinic acetylcholine receptors, which are overstimulated in organophosphate poisoning. While pralidoxime, 2-PAM, can also be used, atropine is the initial and often repeated treatment to dry up secretions and improve bradycardia. Knowing specific antidotes for common poisonings is crucial. Question 16. A 72-year-old male fell at home and sustained a probable hip fracture. He is complaining of severe pain. His past medical history includes atrial fibrillation and he is currently on warfarin, a blood thinner. What is the most significant pre-hospital concern related to his medication? A. Increased risk of pulmonary embolism. B. Potential for increased internal bleeding. C. Impaired ability to metabolize pain medication. D. Risk of stroke due to atrial fibrillation. Answer B. Potential for increased internal bleeding. This question evaluates your awareness of medication impacts in trauma, especially in geriatric patients. The keywords probable hip fracture, on warfarin, and severe pain point to a patient at high risk for significant hemorrhage. Warfarin is an anticoagulant, blood thinner, that dramatically increases the risk of bleeding, both externally and internally. A hip fracture can be associated with significant blood loss, and this risk is compounded by anticoagulant use, potentially leading to hypovolemic shock. While all options have some relevance, the immediate concern in a trauma setting with a patient on blood thinners is uncontrolled bleeding. Always consider the impact of anticoagulants in trauma patients. Question 17. During a rapid trauma assessment of a patient involved in a high-speed MVC, you observe paradoxical motion of the chest wall. The patient is tachypneic and appears to be in respiratory distress. What is your immediate management priority for this finding? A. Administer high-flow oxygen via non-rebreather mask. B. Apply positive pressure ventilation via BVM. C. Stabilize the Flail segment with a bulky dressing. D. Prepare for needle decompression. Answer B. Apply positive pressure ventilation via BVM. This question tests your management of a flail chest, a critical thoracic injury. The keyword paradoxical motion of the chest wall is the classic sign of a flail segment, indicating a segment of the chest wall moves inward with inspiration and outward with expiration, leading to ineffective ventilation. While a bulky dressing can help stabilize, the immediate priority in a patient who is tachypneic and in respiratory distress is to provide positive pressure ventilation. This helps internally stabilize the flail segment and ensures adequate oxygenation and ventilation, which is paramount to preventing hypoxia and hypercarbia. Ultimately, positive pressure ventilation directly addresses the impaired breathing mechanics. Question 18. You are managing a patient with a known history of type 1 diabetes mellitus who is found unresponsive. His skin is warm and dry, and he has rapid, deep respirations, Kussmaul breathing. A rapid blood glucose check shows a reading of HI, high, above meter limits. What is the most likely cause of his unresponsiveness and your primary treatment goal? A. Hypoglycemia, administer oral glucose. B. Hyperglycemic hyperosmolar state, HHS, administer insulin. C. Diabetic ketoacidosis, DKA, manage fluid and electrolyte balance. D. Insulin shock, administer glucagon. Answer, C. Diabetic ketoacidosis, DKA, manage fluid and electrolyte balance. This question requires differentiation between diabetic emergencies. The keywords type 1 diabetes, unresponsive, warm and dry skin, rapid, deep respirations, Kussmaul breathing, and high blood glucose are classic indicators of diabetic ketoacidosis, DKA. DKA is characterized by high blood glucose, acidosis, causing Kussmaul breathing, and dehydration. While insulin is the definitive hospital treatment, prehospital management focuses on aggressive fluid resuscitation to correct dehydration and address electrolyte imbalances, which are often severe. Oral glucose is for hypoglycemia, and HHS typically affects type 2 diabetics without Kussmaul respirations. Your primary role is to support circulation and transport. Question 19. A 30-year-old male is unresponsive after being struck by lightning. He is apneic and pulseless. There are superficial burns to his chest and legs. What is your immediate priority in managing this patient? A. Apply defibrillation. B. Stabilize the cervical spine. C. Initiate chest compressions. D. Secure the airway with an advanced airway. Answer, C. Initiate chest compressions. This question tests the immediate priorities in lightning strike resuscitation. While lightning strikes can cause significant trauma, they frequently result in immediate cardiac arrest due to asystole or ventricular fibrillation. Therefore, the immediate priority is to initiate cardiopulmonary resuscitation, CPR, specifically chest compressions, followed by rapid defibrillation if ventricular fibrillation is present. Unlike other forms of blunt trauma where airway/breathing might be prioritized first, cardiac arrest in lightning strike patients requires immediate cardiac support. Cervical spine stabilization is secondary to immediate life threats. Always focus on reversing the primary physiological insult. Question 20. You are performing continuous capnography on a patient intubated for respiratory failure. The capnography waveform suddenly drops to 0, and simultaneously, the patient's SpO2 drops rapidly. Your first immediate action should be to A. Reconfirm proper tube depth by auscultation. B. Administer an albuterol nebulizer treatment. C. Check for tube dislodgement or circuit disconnection. D. Prepare for immediate extubation and BVM ventilation. Answer, C. Check for tube dislodgement or circuit disconnection. This question assesses your troubleshooting skills with advanced airway management and capnography. The keywords capnography waveform suddenly drops to 0 and SpO2 drops rapidly are critical. A sudden loss of end-tidal CO2, EtCO2, indicates either complete airway obstruction, cardiac arrest, or, most commonly, a dislodged endotracheal tube or a disconnected circuit. Your first immediate action should be to visually inspect the tube's position and connections, and quickly palpate for tube security. While auscultation is important, checking for disconnection or dislodgement is often faster and resolves the issue if it's mechanical. Remember dope, dislodgement, obstruction, pneumothorax, equipment failure. Question 21. A 6-month-old infant is found unresponsive, pale, and apneic. The mother states the infant had a fever all day. On assessment, you note generalized tonic-clonic seizure activity. What is your immediate priority in managing this infant? A. Administer anticonvulsant medication rectally. B. Initiate rapid cooling measures for the fever. C. Establish and maintain a patent airway and provide ventilatory support. D. transport rapidly to the nearest pediatric facility. Answer C. Establish and maintain a patent airway and provide ventilatory support. This question tests your immediate priorities in managing a pediatric seizure, particularly one that is ongoing or has resulted in unresponsiveness and apnea. The keywords unresponsive, pale, and apneic combined with generalized tonic-clonic seizure activity indicate a significant threat to the infant's airway and breathing. Regardless of the seizure cause, febrile or otherwise, ensuring a patent airway and providing ventilatory support, like BVM if apneic, is the absolute immediate priority to prevent hypoxia and hypercarbia, which can worsen neurological outcomes. Anticonvulsants and cooling come after securing the airway and ensuring adequate breathing. Question 22. A 38-year-old male was working on his car when it fell off the jack, pinning him by the legs for approximately 30 minutes. He is now extricated, alert, and complaining of severe lower extremity pain. You note significant swelling and ecchymosis to both lower legs. What is your primary concern for this patient's long-term outcome, and what pre-hospital intervention is crucial to mitigate it? A. Hemorrhagic shock, aggressive fluid resuscitation. B. Deep vein thrombosis, apply compression stockings. C. Compartment syndrome, elevate the extremities. D. Crush syndrome, administer intravenous fluids. Answer D. Crush syndrome, administer intravenous fluids. This question assesses your knowledge of crush injuries and their potential complications. The keywords pinned him by the legs for approximately 30 minutes and significant swelling and ecchymosis are strong indicators of a crush injury. Prolonged compression can lead to rhabdomyolysis and the release of harmful toxins, like myoglobin and potassium, into the bloodstream upon reperfusion, causing crush syndrome, which can result in acute kidney injury and cardiac arrhythmias. Aggressive pre-hospital intravenous fluid administration before and after extrication is crucial to flush these toxins from the kidneys and mitigate the effects of crush syndrome. While compartment syndrome can develop, crush syndrome is the more immediate systemic concern. Question 23. You are assessing a 55-year-old male who complains of acute onset of severe right flank pain radiating to his groin. He is writhing in discomfort. Vital signs are stable. You note he is agitated but denies any trauma. What is the most likely cause of his pain, and what is your most appropriate pre-hospital management? A. Appendicitis, rapid transport and pain management. B. Aortic aneurysm, rapid transport and blood pressure control. C. Renal calculi, kidney stones, pain management and fluid administration. D. Cholecystitis, antiemetics and transport. Answer C. Renal calculi, kidney stones, pain management and fluid administration. This question requires distinguishing between causes of acute abdominal/flank pain. The keywords acute onset severe right flank pain radiating to his groin and writhing in discomfort are classic presentations of renal calculi, kidney stones. While other conditions like an aortic aneurysm can cause back pain, the specific radiation to the groin and writhing pain strongly suggest a stone. Pre-hospital management focuses on aggressive pain management, often with opioids, and intravenous fluids to help with hydration and stone passage. This is a painful but usually not immediately life-threatening condition requiring symptomatic relief and transport for definitive diagnosis. Question 24. You are called to a nursing home for an 88-year-old male with altered mental status. He is normally alert and oriented. Today, he is disoriented, easily distracted, and his attention fluctuates significantly. His family reports this change started suddenly last night. He has no fever or other signs of infection. What is the most appropriate working diagnosis for his altered mental status? A. Dementia. B. Alzheimer's disease. C. Depression. D. Delirium. Answer: D. Delirium. This question tests your ability to differentiate between common geriatric cognitive impairments. The keywords 88-year-old male, normally alert and oriented, disoriented, easily distracted, attention fluctuates significantly, and started suddenly last night are hallmark signs of delirium. Delirium is an acute, fluctuating disturbance of attention and cognition, often with a sudden onset and reversible causes, like infection, medication side effects, dehydration, or electrolyte imbalances. Dementia, including Alzheimer's, has a gradual onset and progressive decline, while depression typically presents differently. Always suspect delirium in an elderly patient with acute changes in mental status. Question 25. You are performing advanced airway management on a 45-year-old male in cardiac arrest. The capnography waveform shows a progressive decrease in EtCO2 values over several minutes, from 40 mm of mercury to 15 mm of mercury, despite continuous high-quality chest compressions and ventilations. What does this trend most likely indicate? A. Return of spontaneous circulation, ROSC. B. Hyperventilation of the patient. C. Improving chest compression quality. D. Decreased cardiac output/perfusion. Answer: D. Decreased cardiac output/perfusion. This question assesses your interpretation of capnography trends during cardiac arrest resuscitation. The concept being tested is the relationship between end-tidal CO2, EtCO2, and cardiac output. In a cardiac arrest, EtCO2 is a direct reflection of pulmonary blood flow, which in turn reflects cardiac output achieved by chest compressions. A progressive decrease in EtCO2, especially from an adequate level, like 40 mm of mercury, to a very low level, like 15 mm of mercury, despite good compressions, indicates a significant decrease in cardiac output and systemic perfusion, suggesting a deteriorating prognosis or ineffective compressions. A sudden increase in EtCO2 would suggest ROSC. Monitoring EtCO2 is vital for assessing resuscitation effectiveness.